So, Danny, can you explain the case?
So, good afternoon. We are presenting a 72-year-old male patient with hypertension, dyslipidemia, and former smoker, chronic obstructive pulmonary disease with bronchospasms. In 2013, the patient experienced unstable angina. A severe lesion was identified in the left anterior descending artery, which was treated with revascularization using one drug, elating stent. From 2013 to 2023, the patient has been experiencing persistent anginous chest pain. 4 coronary angiographies have been performed and no new lesions have been found. The echo, the stress test, EKG, and the lab test were normal. And the current medication include acetyl salicylic acid, amlodipine, oral nitrates, ranolazine, and bisoprolol. Here you can see the angiograms. The right coronary artery and the circumflex artery show no coronary lesions. The left anterior descending artery presents the previous stent without evidence of restenosis or new coronary lesions. Therefore, given the absence of coronary lesions, we propose to study of coronary microvascular dysfunction. So, an index of microvascular resistance greater than 25 or a coronary flow reserve less than 2.5 are pathological values that are associated with a high rate of cardiovascular events. In this patient, we will perform the study of microvascular function using regadenoson instead of adenosine due to the patient's underlying COPD with bronchospasms. Regadenoson not only does not trigger bronchospasms, but also offers advantage such as longer action and a low rate of treatment asystole. Lastly, we will perform a provocation test for coronary vasospasms with acetylcholine. So that's all, and that's not our plan. Alfonso.
Okay, thank you, Danny. Come here if you want, just to help us. And so we are now, the setup is that we have a 6 French radial access, a guiding catheter in place, and now we are starting with the microcirculation study. So you can see, I don't know if you can see podemos girar un poco más la pantalla. We have had some technical problems, so we have to move a little bit the screen just to show you there. The most important thing that is the Coroventis screen in which we are going to study this specific patient with angina and no obstructive coronary artery disease. Connect. So we're preparing the Coroventis software. And the thing is that the patient has undergo 4 or 5 angiographies, as Daniel said. He is still with angina, and he has no explanation for his symptoms. So this is the reason, because we are here doing this study. I think that now in the 21st century, a cardiologist cannot say, we cannot see any epicardial coronary stenosis, just normal coronary arteries. You need to focus also in the microcirculation, that is 95% of the coronary arteries, and study the resistance, the microcirculatory resistance, and also sometimes study the possibility of vasospasm. So we are advancing this wire, that is the software of Coroventis. Is a conventional guide wire to do FFR or RFR. And we are doing with this software all the study in a very short period of time. So this is a conventional pressure wire that you all know. They are seeing the Coroventis screen, Danny. No. Thank you. Está enredada.
Se ve muy bien, ¿eh?
Okay. So we are advancing after zeroing. We are advancing the wire. We are going to equalize, and then we are going to start the procedure. Yeah, Danny showed you some angiographies for the first day, one of the previous angiograms. These are the angiograms of today. But as we have these things that hampers the visualization, it's better to see the previous one. Okay, let's try to. I think the JL4 is not helping so much. I'm going to try to get into the LAD. A test, please. Test, por favor. Okay, the catheter is pointing up. I'm going to retrieve a little bit. I am there. Okay, perfect. So I'm going to retrieve a little bit the wire, extract the introducer. Okay, the blood pressure is okay. Dame nitroglicerina, por favor. We're going to administer some nitroglycerin. Okay, con salino, ¿vale? Con salino. Escopia. Check if
A little more saline.
Yeah. Okay, perfect. Okay, so when the pressure is stable, we can equalize. Patri, ecualizamos. Okay, okay, ya está. Okay. So let's go. Te pongo la cadena. So we're going to advance the wire. I'm going to put a cranial view for that and hold you. Scopia. I think it's okay. You have a previous stent there as a marker, as a metallic roadmap. Probably this is a septal. Or you have to retrieve a little bit. Yeah. There. This is a diagonal or something because the stent is down. You can contrast, please. Okay. Another chance. Just to go down because probably it's another vessel.
Yeah.
Test, please. I don't know if it's the LAD. Let's check it again. It's a diagonal, probably, no?
Yeah.
Probably let's look for another projection. The septal test. Septal again. Diagonal. Another septal, I think. It's quite tricky. Diagonal. Test, please. It's another branch.
Yeah.
Retrieve. Let's put the spider.
In there. Yep.
Yes, please. It's a septal. Another one, another septal. Okay. Yes. No. It's a septal for sure. So you are in the LAD. It's a diagonal. Another one. Okay, you are there, I think. Let's put the cranial view. Mira, ves lo de abajo que yo creo que está chocando. Le quito cráneo. Ahí, vale.
Yeah, that's the point. We are in the stand.
In the proximal edge.
In the proximal edge of the stand. And we go to the septal. Oh.
No, the thing is that for this study, you need to advance. This is the previous branch. You have to retrieve more. You have to advance the wire to the mid distal part. Okay, to the mid distal part of the vessel, 5 to 6 centimeters from the ostium. After equalizing, we don't see anything with this. Scopia. Test, please. Probably it's septal.
Yes, it's septal.
Okay. As you can see, there is no restenosis at the point of the stent, no new lesions. No te salgas, que te ha costado mucho entrar.
The wire,
the wire is a little bit damaged, or it's not easy to advance.
No, rotate.
Push it if you need like that. Perfect. I did it more. Probably there is a good side because it's distal to the stent and 5 to 6 centimeters from the ostium. Okay, so we need to administer saline, hold the wire. Until we don't see anything. Again.
More.
Okay. Just as information, we are going to measure an RFR. Because it's quite easy to do that with the wire here. Okay, press the... Okay, live, vivo. En vivo, Patri, o María. Another measurement. Okay, en vivo. So it's not one.
It's not one.
It has a previous stent. So the equalization was perfect. So we are going to move to the other mode, to CFR IMR. This one, okay. Yeah. So we are starting with the microcirculation study, microvascular dysfunction, and then if we can see anything, or even if we do, we are continuing with the vasospasm study. So for this study, we are doing with the tremor dilution method with the Corroventis system. As you can see in the screen, you have resting measurement and also an hyperemic ones. So we have to perform with the injection of a small amount of saline, 3 measurements of transit time, just to have the resting measurements. And then we induce a hyperemia. In this case, we are using regadenoson, as Daniel said before, because of the respiratory things. And then the software, the Corroventis software, is going to give us everything: FFR, IMR, CFR, and we need afterwards to interpret the results. That not always is easy. So we are starting with some jeringas de salino, las tienes perfectas, with the resting measurements. So Danny is going to inject saline, and as the transit time is proportional in an inverse way to the injector, to the cardiac output, we know that looking at time, the transit time, we know the flow. The first measurement is okay. If you do very fast or very slow, the software is going to tell you, and you have to repeat. In the resting mode, it's not so difficult because you have the time you need, but you have to do the same during the hyperemia. So Danny has done, I don't know if perfect, because we have very different measurements. We can delete the last one probably and repeat, and then think if the first one is the bad one. Maria, can you delete this one, please? Eliminar. A la derecha. ¿Tienes marcada? Bueno, borra esa, sí. La primera, venga. We're going to delete the first one that probably is the most different from the other. ¿La vas a eliminar, María, o no? Sí, vamos a repetir. ¿Con esto vale?
Inyectar, ¿no? Okay.
So we are going to inject an error.
Okay.
We have to inject it
Inject
again. As is said before, the software is going to tell you.
Okay. Closer, but
Closer. I don't know if we have to modify the last one. You see, we are doing always 3 measurements to be the more accurate we can. And if not, we can choose. Yeah, okay. I think it's okay. Yeah. I think it's quite accurate. So now, as the software said in Spanish, we have to induce hyperemia. And in this patient, we are using rogadenosone and repeat the procedure again with injection of saline, as Daniel did. Yeah. Vamos a ponerte una medicación. Puedes notar alguna sensación desagradable, es normal, ¿vale? Si notas cualquier cosa, nos lo dices. So we are using rogadenosone for patients with asthma or bronchospasm with very good results. Probably you can explain the difference again between rogadenosone and
yeah, it's longer effect. The effect is like 4 minutes, 5 minutes. Yes. No bronchospasm and no asystole. It's the 3 better.
Probably a bigger decrease in blood pressure with rogadenosone, and the effect starts at 1 minute and something. Probably we are looking always to the mean pressure. And when you see this PDPA, these changes, you start with a
little more symptoms with rogadenosone. Some nervous, some anxiety. Chest pain.
You see the PDPA, 0.93 is coming down.
Yeah.
Wait a little bit, probably.
Yeah, we wait.
It's going down.
We have 5 minutes, so.
It's an advantage of using. It's going down. Adenosine. Look the pressures. It's the funny movement they do always with this adenosine or rogadenosone. And also, I listened to one conference in the EuroPCR that said there are some ongoing publications saying that probably it's better to use intracoronary adenosine than intravenous adenosine. Mm-hmm. There are different options. I think we can go. Huh?
Yes, it's very starting. So here we go. First,
you need to inject 3 cc's of saline with the proper speed. Look how the transit time has decreased because the hyperemia has been down. 0.5, the first measurement, 0.6, very accurate. 0.6, perfect. Yeah. So we press the final blue button, and now is the difficult part of the study to interpret the results. So look, it's quite interesting because we have an FFR of 0.92. This was the thing that we expected because the angiography was almost perfect. The stent was okay. And as you can see, we have a reduced CFR. You know, the CFR is the reserve, that is the quotient between the hyperemic flow and the basal flow. So the normal value is over 2, and we have a reduced CFR. And IMR, that is the microcirculatory resistance index, should be below 25 in stable patients. So in these patients, we have clearly, another is difficult to analyze, but in this case, it's clear that the patient has an structural microcirculatory dysfunction, no? That explains probably part of the symptoms. So in some cases, the study is finished now, but I think it's more interesting to continue and complete all the study to know if there is some vasospastic factor associated with this one, just to choose the best management for these symptoms. No? Sure. Okay, so we are going to move to the vasospastic test. So we need the 12 leads ECG. We have it there. I don't know if I know you can't see it, but we have it. And we are going to administer different doses of acetylcholine, and an endothelial-dependent vasodilator. And in a normal patient, this drug is going to vasodilate the vessel through the nitric oxide, no?
Yeah.
But in patients with endothelial dysfunction, it's going to do different things, not vasodilating or even producing vasospasm. So we are analyzing that. We are starting with the low dose. Pati, ¿la tienes preparada?
So the test is positive if the patient develop chest pain. The spasms is more than
Nosotros.
90%.
Nosotros. Acetilcolina.
And the spasm is reversible with nitroglycerin.
Well, we prepare this is a very important point and a difficult one to prepare the acetylcholine. We have to remember all the maths and the calculations, but we need to be very accurate with this. Some groups are administering it in 20 seconds, others use 3 minutes. So probably in the middle is the virtue. And it's important to say that the majority of this acetylcholine is going to be in the guiding catheter. So after that, we have to flush it with a syringe very slowly. We have to be prepared with atropine, that is the antidote of this, and explain the patient that he needs to tell us if he feels the same symptoms that he suffered at home, and also see the angiography, the ECG, and the blood pressure. So probably we need to check the best angio we have to see the possible spasm, probably the cranial view. But with these electrodes, it's difficult to find. I don't know. All right. You can have radio-transparent electrodes that we don't have now. It makes easier the procedure. Tess, con contraste, por favor. I did more. Hay agua por todos lados. It's not bad here, I think. Okay, let's do a cine just to have as a basal angiography. Okay, perfect.
We have 2 questions for the audience.
One question.
Okay.
Yeah, the first one is good agents.
Dani.
The first question is for patients with microvascular dysfunction, is it important to modify the cardiovascular risk factors?
It's a very good question. We have introduced that there are several endotypes of INOCA or ANOCA. One is the isolated microvascular dysfunction with IMR elevated and CFR low without a spasm. Other one is vasospastic epicardial angina with normal IMR but vasospastic angina, positive test that, as Daniel explained. The other one is to have microvascular spasm, that is normal IMR, no epicardial vasospastic angina, but the patient with acetylcholine suffer chest pain and ECG changes. And you have the combined endotypes and also a normal, everything is normal. That is always important because the patient has had 4 times in the cath lab without any explanation of their symptoms. No? So in all these cases, modified risk factors, hypertension, diabetes, smoking cessation, exercise is the first line of therapy. And then regarding the endotype you have, you modify the drugs. Another question?
Okay, thank you. Yeah, there are a lot of more
questions.
Yeah.
Okay, we have time.
The next one is what agents beside adenosine can be used to agents, medications.
Different from adenosine.
Yeah.
Well, we have a very good experience with adenosine from a long time ago, and we use intravenously for this procedure. But as I said, there are some ongoing publications of using also intracoronary. And in patients with asthma and problems of bronchospasm, we can use rogadenosone in this patient. And some people are using papaverine, but also with some complications, ventricular arrhythmias or so. So it depends your experience, but I think with adenosine we have a very good experience, and rogadenosone is an also safe alternative.
Okay, thank you. The audience asked if the reproduction of the symptoms of the patient is not a very objective form to.
It's true. It's true. The symptoms is not very objective, but it's the reason that modify your treatment in heart failure, angina, and everything in cardiology. So you know the New Heart Association classification, the CCS. All of these classifications are subjective. So we have this, and also we have an objective number there with the IMR. Of course, it would be perfect if we have a number also to accurately measure the vasospasm as well, not only the angiography and the symptoms.
Yeah. And there are two more questions. The first one, what can be the effects of spillover of acetylcholine?
Spillover?
Of acetylcholine.
Yes.
What I didn't.
The effects of
what can be the effects of the spillover of acetylcholine?
Well, there are no much effects. Chest pain is the first and the more frequent effect. Sometimes hypotension, bradycardia, and that's the
main things are this one, arrhythmias and heart block. So the antidote is atropine. You have to take into account and inject very slowly. This is the thing.
One person asks, he says that it's a great case, and if it is common, do you see this?
Yeah, probably is more frequent than we are. The studies we are developing. So the patient with chest pain and no coronary lesions is very frequent, and probably much of these patients have
in registry of 100,000 patients with angina and ischemia indeed. The non-obstructive coronary artery disease is observed in more than 50% of cases. And if we are talking about women, even up to 70%.
Yeah.
So,
sorry,
the next question.
It was about that, about women, the prevalence.
The prevalence of microvascular dysfunction is that the number, the 70%, up to 70% of the patients that comes with angina, women, without epicardial obstructive coronary artery disease. And from these patients, if you do this kind of a study, 50% more or less has some of one of these endotypes. So this is a thing we are not studying because we are trained to open block arteries and to do CTOs and all these things and to put stents. But I think we do more than we do now. We need more drug to do the treatment because we are accurate doing the diagnosis, but we need the treatment.
Yeah. And the last one, is there any single parameter that would be the most prognostic in these patients?
And there is no a single parameter because we have seen that CFR and also FFR for sure and IMR alone are prognostic parameters. But together, if you combine the CFR, a low CFR and high IMR, probably these patients have the worst prognosis. And if you combine this with the vasospastic angina, they are the worst.
Yeah. And we have one more comment.
Not only in coronary lesions, if not true in cardiovascular general.
In general.
Yeah.
Okay, the last question and we continue.
Yeah. And it is about such cases demand a profound understanding of coronary physiology. For accurate results, should such cases be referred to an expert center?
I don't know. Coronary disease is quite frequent. I think you depend on this kind of softwares. If you have this software and you are a cardiologist, an interventional cardiologist, I think everyone should be able to interpret these results. Sometimes it's difficult, but I don't know.
Okay, thank you very much.
Let's go. Okay. So we are going to start injecting 1 microgram, 1 or 10. This is? Okay, the first one. So very slowly.
Yeah.
the first dose of, we are checking the, si notas dolor en el pecho, como el de en casa, nos lo dices, ¿vale?
Yes. 10 micrograms.
Sí, muy despacio. Very slowly, we are checking the ECG. Patri, te diremos que imprimas al momento. Esto es agua, ¿no? So Danny is administering the acetylcholine very slowly. After that, we're going to flush the catheter. ¿Alguna molestia? The patient is telling us he has some chest pain. Nos tienes que decir si va a más, está igual o menos, ¿vale? Sometimes it's difficult, but because as you said, it's a subjective theme. I can't see any difference in the ECG. Very slowly. And after that, we are going to do an angiogram in the same projection. I'm going to check the previous one just to have it in mind. Okay. Remember that image?
Well,
Okay.
It's enough.
Okay. Ojo esta. Isoscopia. This is another controversial thing about the wire. Some people retrieve the wire a little bit because the wire can produce vasospasm. Another maintain the wire just to check for a safety reason and also to check the velocity and with the coroventis on. I think we should retrieve a little bit the wire, just a little bit, to maintain the position of the guiding catheter just in case we need to inject nitroglycerin or something in the stent. Probably okay. Let's do a scene here. I think it's similar. ¿Cómo van los síntomas? Igual. The patient is the same. Okay, let's go for the second. We have to wait a couple of minutes or 3, but while we prepare the second dose, there are different protocols starting from 1 or 10 micrograms to 20 and 100. And some people, with 100 don't see anything, administer 200. And also another controversial point is that sometimes people move to the right coronary artery to do the same procedure, and to up to 20% of cases find something. We, to be honest, do always in the LAD in the majority of cases. Vamos, espera un minutito más. We are waiting a little bit more. ¿Hemos completado Parina, Patri? Sí, ponle 2000 más. Okay, I think we can go with the second dose. This 20 micrograms, 20 micrograms of acetylcholine, very slowly. Sí. We are looking to the ECG. Lo mismo, ¿eh? Si notas que va más o menos, nos lo dices. ¿Qué tal va el dolor? Igual. Ok. Poquito mejor. If you, with one dose of acetylcholine, you see a severe spasm and you have the diagnosis, you can immediately administer nitroglycerin, that is the antidote. And this is the reason, because it's safer doing this here, that the non-invasive provocation test of vasospasm, because here you can administer nitroglycerin inside the coronary artery. ¿Cuánto llevas?
1 minute.
And of course, you can measure the CFR with the other non-invasive techniques, but the IMR, you can only measure here. And as we said before, the complementary performance of the vasospastic test can only be done here. ¿Qué tal? The patient is the same.
Well,
¿Esto qué era? Okay. We have flashed very slowly the catheter, so I am flashing with contrast again. Let's check if we have some spasm. Probably it's a little bit different. The ECG is pretty the same, I think. Probably it's a little bit different. No?
Yeah.
Cine? No. It's pretty the same.
Yeah.
Okay. We can wait 1 minute more and go for the dose of 100
micrograms.
micrograms. ¿Lo tienes aquí? Sí, ¿no? Vamos a esperar un minutito. ¿Qué tal? Igual. So I think if we reach the dose of 100 micrograms and we don't see any spasm epicardial nor microvascular, it's quite reassuring. And also we have an explanation for the symptoms with a very high IMR. So in this case, which treatment would you recommend?
So at least Adiro, acetyl salicylic
Acid?
acid, yeah. High power statin. It is not clear about
ECA inhibitors, probably.
ACE inhibitors, yeah. Beta blockers or the hydropyridinics. I think is the
main part is if you have a isolated vasospastic angina, you have to avoid beta blockers. But now in this phenotype, you can use almost all the drugs. Okay, this is the 100 dose syringe. It's very important to have the different syringe for this thing and to mark them properly, because one confusion could be complicated. ¿Qué tal? Un poquito más. The patient is complaining a little bit more of chest pain. We can see anything in the ECG. Blood pressure is okay. Well, I will explain you later. Let's finish this administration. Is there any other question, Clara? No está clara. Sí, dime.
Yeah, there are 5 more questions.
5 more.
Yeah. The first one is that are there any contraindications for this procedure?
I don't think so. If you consider all the comorbidities of the patient and you use regadenoson in patients with asthma and the usual contraindication of these drugs, there is no clear contraindication. But you need to know all the comorbidities of the patient and be safe, no, in these kind of procedures.
Okay. The next one is: are you satisfied with results of physiology guided management in these patients?
Yes, to be honest, we don't have a specific outpatient clinic to follow these patients. Our colleagues from the clinical cardiology department follow them. But I think if you have an explanation, a physiological explanation for the symptoms, and you direct the treatment for these, patients improve. And we have data of the Cormica trial as well. So it's not only an impression. ¿Qué tal?
Yeah.
¿Esto era agua?
Yes.
Ok. Imprime el electropadre, ¿vale? Escopia. The patient is complaining for more chest pain. I don't know if it's typical or atypical. Okay, let's do a cine here.
Yeah.
To be honest, I cannot see any vasospasm there. Probably there is some microvascular spasm. If we review the ECGs here, from here, I cannot see any difference of the ECGs.
maybe some ST tanks very
Yeah, very slight, very
Yeah.
flattened ST, probably.
after.
Probably this is a combination of endotypes, and probably has a structural dysfunction with a high IMR and also some microvascular spasm, because epicardial vasospasm, I think, is ruled out.
Is good.
Okay. So what have we do? What do we do? Another dose, or I think we can finish here because the vasospastic angina is ruled out. We can check the ECGs now. And the other thing I wanted to explain before finishing the case is that the nitroglycerin, we are administering nitroglycerin and doing a final angio, is another controversial point, because the patient is on drugs with anti-anginal medication. And if you are a puristic guy, you need to retrieve all these medications probably the day before, just to have a pure study. Probably these drugs are interfering in the results, and probably the vasospastic thing, or also the IMR could be a little bit different, but it's interesting to see how the patient behaves with their usual medication. And the way we work, we cannot schedule all the patients, and the patient comes with angina, you do the angio, and you continue in the same procedure as almost always with this kind of studies. No? I think it's pretty the same.
Yeah.
So the conclusions of the study could be the stent is normal, no epicardial artery disease, and structural or vasospastic. Probably the main problem is a structural microvascular dysfunction, and probably associated a slight microvascular spasm as well. Can we see the ECGs? ¿Nos enseñan los electros?
So probably beta blockers in this patient will be removed and
try. Yeah, because the patient with beta blockers, I don't know if you can see the ECGs. ¿Este es el primero? ¿Cuál es? No, del basal. This is the basal ECG, and the last one? No, the last one. Sí, el último. Slight changes that I don't know if are significant. Okay, but the patient is with angina, on beta blockers, and probably is a component of microvascular spasm. Probably it's time to change to calcium channel blockers, probably, and doing something different for him because he's on pain. So I think we have finished the procedure, right?
Yeah.
So let's retrieve the wire. We can do a pullback. Put the ponéis el RFR, el modo, porfa. Bueno, o con esto. Is there another question?
Yes.
Yeah, we have many more questions. Some of them we have already answered. And one is if physiological tests are negative, but the patient remains symptomatic, would you repeat the test?
It's a very good question. Some authors says that there is an entity that exists that is the sensitive heart. This is the patient that have a normal of this study normal, but this is the patient you inject only contrast and suffer chest pain. And there are some studies in the past saying that with tricyclics and this kind of drugs, the patients go well. I don't know. There are other therapies, not only medication, but also a sinus reducer or other therapies that could help. But we really need a drug designed for this kind of endotypes. I know there's some ongoing trials, but we need to focus the big pharma industry in this scenario.
Okay. And the two last questions are, does aminophylline also work as an alternative to nitroglycerin?
We don't use it, to be honest, but you can use as an antidote, of course.
And the last one is, at what stage will you consider referral for studying other diseases like esophageal disease?
It's a very good point. And a study, when you have a real negative study and you are not sure about the symptoms, you discharge the patient. So the patient who has undergone 4 or 5 catheterizations, and you explain, no, you don't have the biggest probability is that your symptoms are not related with the heart, because the medicine is not black or white, but almost with certainty your problem is not cardiac. So at this point, the patient reassured, and some of them improve as well. So you
Okay.
refer to the to a specialist.
Okay, we have one more.
Okay.
Would it make sense to even review left ventricular function with physiological testing and with transesophageal echocardiogram?
I don't know if doing a transesophageal echocardiogram to all these patients makes sense. It's important, we haven't done in this case, to measure the left ventricle end diastolic pressure, just to discard diastolic dysfunction that can explain some symptoms. And an echocardiogram, of course, is a mandatory test before this thing, no? But transesophageal, I don't know. I don't know for the patients.
Okay, thank you very much.
Thank you, Clara. So I think that's all. Thank you for being with us another Wednesday, and see you next week. Bye-bye.
Ha ido muy bien, vale.